Good morning, everyone. I'm Dr. Amber Yates. I'm a pediatric hematologist here at Texas Children's Hospital. And this morning I'm going to talk about treatment advances in sickle cell disease, which 5 years ago would have been a very, very short talk, about 5 minutes, because there wasn't a lot to talk about. But today I have a lot to tell you. So today I want to talk about the pathophysiology of sickle cell disease. That is, what is happening in sickle cell disease and what causes the damage, the problems that we see in sickle cell disease. I want to talk about what current treatments we have right now, what therapeutic options we have, demonstrate the limitations of that treatment, where are the opportunities for new treatments, and then compare some upcoming therapeutic options for this disease. So I think this picture is always shown when we talk about sickle cell disease. It's what's classically described when we talk about sickle cell disease. So at its heart, sickle cell disease is an inherited disorder of the red blood cell, where this tiny, tiny change in the gene, a single amino acid change, causes a cascade of events where the red blood cell, which should be round and soft like a donut, changes shapes to this long sickle shape, which you can see in this photograph can get stuck in the blood vessels and block blood flow downstream, causing a lack of blood flow to tissues and organs. And then here in the United States, there are only about 100,000 people affected, which is a lot, but worldwide there are millions affected with this disease, and that's why it's so important to come up with therapeutic options for this condition. So this is really the therapeutic option we've had for sickle cell disease for a long time, and this is kind of a great look at what treatment has meant for sickle cell disease. If you'll see on the very left-hand side, we started looking at hydroxyurea as a treatment option for sickle cell disease in 1984. It's 2019 today. And you can see there's a myriad of things happening here. Most importantly, that in the kind of the mid to late 90s, we started looking at hydroxyurea as a treatment option for children with sickle cell disease. But there's just multiple trials as you go on, and there's a little bit more to tell, and that it really wasn't into the 2000s where the National Heart, Lung, Blood Institute said that we had enough information that we should give this medication routinely to children with sickle cell disease starting at 9 to 12 months of age. But it was only in the last 2 years that we finally got FDA approval for this medication for children as young as 2. So what are we looking at? 30 years with the same medication for this disease with no other changes. But, you know, it's not all bad. Hydroxyurea works. It really, really works. And that's why we're happy to have it. It causes fetal hemoglobin, which is a protective hemoglobin, keeps the red blood cell round and from sickling. It causes production of that. It decreases the white blood cell count and the reticulocyte count, which is important because the white blood cells and the reticulocytes stick to the sickle cells, and then they stick to the blood vessels, and so causes the clumping and sticking that we saw in the picture. It increases the hemoglobin so that the patient is less anemic, which is of course a very crucial component of sickle cell disease. It's been proven time and time with multiple studies to reduce the number of pain events and lung complications called acute chest syndrome. It has reduced the number of transfusions. So if you start with a higher hemoglobin, you're less anemic. If you get sick and that number drops a little bit, you're still higher than you were previously, and you're less likely to need a transfusion. And more important to me as a hematologist, their lifespan has been extended. It's not as short as it was previously before we had treatment option. So we've got lots of evidence that it works, and it works really well. But that's not all of it. It's limited. It doesn't work. It's been studied only really in the severe forms of sickle cell disease, of SS and sickle beta 0 thalassemia. There's been small studies in the more moderate forms, SC and S beta plus thalassemia. We've really never gotten a large study of information about hydroxyurea in those patients. It is at its heart a chemotherapy medication. There's just no way around it. It requires careful monitoring with labs, so patients have to come in frequently. It does require what we call a dose escalation, where we start at a low dose and work our way up. So it can take up to 9 months to get a patient to their perfect dose, which is a long time for patients to wait to get to a good dose. It doesn't come in a liquid freely, so we have to compound that medication. You might think it's hard to get a compounded medication. If you compound a chemotherapy, you even made it harder. And so a lot of our patients are dependent on our pharmacy here at Texas Children to get this medication. And not all patients respond equally. And this is something we actually don't understand at all. one patient may have an amazing response and have almost no events and almost never need the hospital, and another patient might have almost no response, even though they're taking the medication every day as we ask them to. And so we don't really understand why there's that variability. So as you can see, there's some room for improvement for these patients. Also, what we've learned, as opposed to that picture at the very beginning where we thought everything with sickle cell disease had to do with blocking the blood vessels and preventing blood flow to tissues, there's a lot more going on. And so we also know that the red blood cell breakdown, which is called hemolysis, causes damage in the blood vessels, which we call oxidative injury or oxidative stress. We know that these adhesion, the stickiness of the white blood cells and the red blood cells that stick to the blood vessel walls are important. There's a lot of inflammation happening in the red blood cell, in sickle cell disease, and this also plays a role. And there's also some activation of the coagulation system, the clotting system, that leads to some of this. And so as you can see, all of these other changes that are happening in sickle cell disease would be potential areas that we could use a treatment for that might improve the life of these patients. And that's exactly what's happened over the last several years. So let's talk about some of them. So the first medication that we have is Indari. That's its brand name. It's also called L-glutamine, which is what it is. So we're talking about that just a while ago. Oxidative stress, this it's kind of like a battle of the enzymes, the chemicals inside the red blood cell, and basically the ratio, the pluses and minuses are off in sickle cell disease. And we know that L-glutamine, this amino acid, is required to produce some of these chemicals that your red blood cell needs. And they've shown in some earlier studies that this amino acid could improve this ratio and make things better, and that patients said that they had less pain when they took L-glutamine. And so with these earlier studies in mind, they decided that they would move forward with some more larger studies. And they did. And so they did a large-scale placebo-controlled trial with L-glutamine, and they saw a reduction in pain events. So this is about a year of treatment with L-glutamine, and the patients who received L-glutamine had 3 pain events in a year compared to 4 for the patients who received placebo or the no medication. And then when you compare it to hospitalizations, 2 hospitalizations versus 3, which doesn't sound like much, but over years and years of your life, it adds up after a while. They also noted that the patients who got L-glutamine had a longer time period before they had that very first crisis. So more days without pain before they had that crisis. So 84 days versus 54 days for those patients who were not receiving the medication. They also had fewer acute chest syndrome events, which is a very serious lung complication. So 8.6% of the population in the study versus 23.1% of the population. And all of this information that there was really no safety concerns and that there seemed to be good indicators that this improved the life of patients with sickle cell disease. This led to FDA approval in 2017, so for patients 5 and over with sickle cell disease. So this is our second medication, approved almost at the same time that we finally got FDA approval for Hydroxyurea. So this is a fun one to say. So Voxelotor, which is also known as GBT440. So this one is one of my favorite to describe. It's a little tiny molecule that inserts itself into the hemoglobin, which is a protein inside your red blood cell. And that's where the problem is in sickle cell disease. And what it does is, the problem in sickle cell disease only happens when your red blood cell gives its oxygen away. And so this has the red blood cell hold on to the oxygen just a little bit tighter, not give all of it away, which is perfectly safe. And so it prevents those long strands that deform the red blood cell from happening. And it's a once daily oral medication, so something that would be really good for a long-term medication. And so they moved forward with what's called the HOPE study. Again, a placebo-controlled double-blinded study, patients from 12 to 65. What's interesting about this study compared to some of the other studies is included all forms of sickle cell disease. So the severely affected patients that we classically see, SS, and the sickle beta 0 thalassemia patients, but also SC patients and sickle beta plus thalassemia patients, which is a new thing. So it was nice to see that those patients were included in this study. And basically, the patients who were eligible for the study are kind of the same patients who've been eligible for any treatment study in sickle cell disease ever, that they've had painful events requiring either like ER visits or hospitalizations or an acute chest syndrome event in the last 12 months, which is pretty standard. And what they noted is that they had 2 different treatment groups. patients could either receive 900 milligrams of Voxelotor or 1,500 milligrams of Voxelotor. And what they noted is in that higher dose group, that 60% of them had their hemoglobin improve more than 1 gram, so less anemic, and about a third of the patients in the 900 milligram group had more than a gram improvement. So showing that it did appear that that higher dose had a more significant change for more patients, and so that was a huge benefit. One of the other things they wanted to look at is the red blood cell breakdown, the hemolysis, and so the bilirubin is a marker of that. And so they showed that the bilirubin levels were reduced in the patients, both doses, either the 900 or the 1,500 milligram was reduced, and other markers of hemolysis like the reticulocyte count and other things like that also indicated that the amount of red blood cell breakdown that they were experiencing was less. What they didn't show was that there were any less pain events in those patients receiving the medication, but this was a relatively short study, and it's actually not a negative result. The fact that they had improvement in their anemia and didn't have increased pain was actually a good thing. Sometimes when we improve the anemia in sickle cell disease, we can actually make sickle cell pain events more frequent. And so the fact that that didn't happen in this study was actually a useful thing to find out. So they're doing longer studies to see if there is any pain event improvement long term. So now what for this medication? So number one, those patients who were on this original study can continue the medication if they felt like it was beneficial for them in an open label extension study. Now, I think one of the most exciting things is they have opened it up for an expanded access program, compassionate use. So this means if I have a patient who's severely affected with sickle cell disease and maybe took hydroxyurea and still is suffering and is not improving, and who's very, very anemic despite taking hydroxyurea, just like I asked them to, that I can apply to use this medication in that patient for compassionate use. And so that is in the process of rolling out across the United States for these patients. It's been approved by the FDA for an accelerated approval pathway through the Orphan Drug Program, and it's going to be opening up for studies to study this in children. So this initial study started at 12 years and older, and so eventually they will be starting studies in pediatric patients so we can find out if we can start it even earlier so that our young patients with sickle cell disease will have this as a treatment option. So super exciting. So this is another mouthful. This is Crizanlizumab, our SEG-101. It shows that stickiness, the blood cells sticking to the blood vessel wall, is super important in sickle cell disease. And so it's not just about the red blood cells, but also those white blood cells. And we actually know that how much stickiness there is to the blood vessel wall actually correlates to how well the patient does or doesn't do and how severe their disease is, which is fascinating. And so all of that process is thought to be move forward through a particular thing called P-selectin. And so this medication is an antibody, what's known as a humanized monoclonal antibody to that P-selectin. And so it works to inhibit that P-selectin so this adhesion can't happen, and therefore the red blood cells and the white blood cells wouldn't stick to the blood vessel wall, and so hopefully preventing issues. So they did this study called SUSTAIN, and it was really just teenagers and adults, so 16 years to 65 years of age. It again had a huge group of patients that all forms of sickle cell disease were invited to participate if they had painful events. So they had to have a pretty decent number of sickle cell events, so they described it at least 2 in the prior 12 months. And you could get either a low dose of Crizanlizumab, a high dose of Crizanlizumab, or placebo again, trying to figure out what would be the better dose and if it was different than patients who didn't get the medication. This medicine is different than the prior two that I've talked about. This is an IV infusion that would be given once a month. So it's definitely a different version of a medication that would be given differently and not something that would be taken orally daily. And so what they saw is that the median number of crises per year were different in the groups. So you can see that in the patients who didn't receive any medicine, that they had almost 3 crises per year. But in the high dose group, they had 1.63 crises per year, and this was significantly different, these two groups. It was reduced in the low dose group, but it wasn't enough to be a huge difference between that group and the placebo group. And again, this idea of how long did it take to have that first pain event. And so in the placebo group, it only took a little bit over a month, but it took up to 4 months in the group that got the high dose group. So again, prolonging that time period until that a painful event was occurring in this patient population. So kind of the flip side of Voxelotor, this patient population, they saw improvement in the pain events, but no significant difference in their labs. So there was no improvement in the hemoglobin, no reduction in those red cell breakdown markers, so kind of the opposite. So definite improvement in pain events, but no improvement in the lab changes that we see in sickle cell disease. So now what? So again, we're getting progress because the FDA granted them breakthrough therapy diagnosis. And so they're working on developing a phase 2 trial so we can start using this in pediatric patients. And they hope ultimately to potentially have it down to 6 months of age for this medication as well. So again, another medication that hopefully long-term will have pediatric indications. So I can't leave a talk about therapeutic options without talking about sometimes we don't do, it doesn't work out. So ribopancil, it can't all be good. So ribopancil works similarly to Crizanlizumab, except it does more than just the P-selectin. It kind of wipes out all of these selectins that you have. And so they were using this medication in the midst of a pain event. So a patient would get hospitalized for a pain event. They would get this medication alongside their IV fluids and their IV pain meds. And the hope was that if we gave this medication, maybe they wouldn't have to be hospitalized as long. Maybe they wouldn't need as many pain medications, as many doses, that their pain numbers would be better. So that we could hopefully actually treat the pain crisis that's happening, not just give them pain medications. And so again, this was ribopancil versus placebo. And so they started this trial in 2015, and we just found out in the last month that they failed to meet their primary endpoint and that wasn't going to be successful. And so the study has now closed. So trying our best, it doesn't always work out, but you know, hopefully we'll figure out something else that we can use for that particular crisis. And no talk about treatment options with sickle cell disease, I think, would be complete without talking about gene therapy, because it's definitely the thing that my patients are asking me about most, and families. So gene therapy, I think the best way to describe it is kind of like an auto or a self-transplant. So you're using your patient's stem cells, those cells that make up our other cells. So these are the cells that make your red blood cells and your white blood cells and your platelets. And you take them from the patient and you take them to the lab and you use a virus that can't make you ill, and you make that virus produce hemoglobin that doesn't sickle. And there's lots of different ways to do this. Some people choose a hemoglobin that's similar to fetal hemoglobin, and some people choose one that's similar to A, which is the normal hemoglobin. And so the one that has the most information right now is lentiglobin. And so it's uses this hemoglobin that has this really funny name, hemoglobin A T87Q. And what's special about this one is it's a non-sickling hemoglobin. It's kind of similar to hemoglobin A, but also it has a property that inhibits sickling in the red blood cell itself. So it has kind of two properties. It works by reducing the amount of sickle hemoglobin in the red blood cell, but also actually prevents that elongating hemoglobin. But I think it's important to talk about gene therapy and the fact that gene therapy does require chemotherapy. We need to kind of make space in the bone marrow for these cells to take home and reproduce the cells. So it's not necessarily going to be an easy treatment and not for everybody. And so it is, you know, progress, but it's going to be something that not all families are interested in. And so what we know so far is pretty limited, but it's looking promising. So far we have 8 patients who have at least 6 months of follow-up. And so of all of their hemoglobin, 4.5 to 8.8 of that is this hemoglobin that they induced into the patient, the hemoglobin A T87Q, which is amazing. And overall, these patients had hemoglobins of 10.2 to 15, which is unheard of in my patients. The average patient with sickle cell SS has a hemoglobin of 6 to 8. So these are normal, near normal or normal hemoglobins. So it's amazing. They were able to reduce the sickle hemoglobin percentage down to less than 50, which is actually what we would like. So similar to somebody who has sickle cell trait, which would be optimal. And so far in this small group of patients, they have not had acute chest syndrome events, and they have not had a pain events so far out to 15 months. So looking very promising, but it's early. These are teenage adult patients, so we still have some work to do to see if it would work in pediatric patients or how long this would be good for. So still a lot of information to find out about this as a long-term therapy, but super exciting. And I think also everyone has heard it. I think it's been on the news like every other week, and that is another form of gene therapy called CRISPR-Cas9. And so what this does is it uses a tool to kind of cut out what you don't want in your gene, and so that you can get rid of a gene or condition. And so in sickle cell disease, what you can do is get rid of a gene that turns off your fetal hemoglobin production. And so what we know is newborn babies with sickle cell disease actually don't have any sickle cell complications, and that's because they make tons and tons of this hemoglobin called fetal hemoglobin, and that protects the red blood cell from sickling. And so if you could make a lot of fetal hemoglobin, you could protect your red blood cell from sickling. This is how hydroxyurea works, right? By producing more of that fetal hemoglobin, but it can't do the same as when you're newly born and you make a lot more of this. So this is what the CRISPR-Cas9 studies are hoping to do, is to remove a gene that turns off that production so that you can go back to how much fetal hemoglobin your production. So just starting clinical trials in adults, so we're not sure where that'll go, but another way that we can use our genes to hopefully cure this condition. And so thoughts about the future is that I don't think when I started this career in sickle cell disease 10 years ago that I would be so excited about all the options that I have. I think there are questions about who gets what medication and how we make those decisions. How do these medicines compare to hydroxyurea, right? I have 30 years of proof and principle and efficacy and lots of information about hydroxyurea. Maybe there are patients who might benefit from more than one of these medications, the combination of medications because of their particular disease. Maybe you do one to improve their hemoglobin, but you need another one to control their painful events. So who knows what that might look like. And then, of course, the age-old question of we've got to get insurance companies to understand that getting these medications covered is important and hopefully would prevent patients from needing hospital stays. And so that'll be a crucial component of getting these medications going forward. Thank you for your attention. I appreciate it. Thanks for having me.